So first of all, I just wanted to say an enormous thank you to Thrombosis UK and Professor Hunt for inviting me to speak on this important topic today. In the course of designing other research in this area, we've spoken to many women who have had the experience of having thrombosis during pregnancy, and hearing firsthand their accounts of what a terrifying experience this can be. It's really highlighted again, in addition to the incidents, the importance of this work. So the rationale for research into this area: in 3-year periods, maternal and perinatal deaths and serious morbidities in the UK are analysed, and an annual report is produced. So post-mortem reports, medical records, local multidisciplinary healthcare professional records and multi-agency reports are all looked at. And then these are reported annually. So for example, the 2024 report looked at all cases from 2020 to 2022, and that's reported in something called the Embrace UK report, Mothers and Babies Reducing the Risk Through Audits and Confidential Inquiries. So in their 2024 reports, it was sadly identified that blood clots, so venous thromboembolism, VTE, was the leading cause of death in pregnant women. And interestingly, they also found that 1 in 4 women who died from VTE died in the first trimester from their pregnancy. Why this is particularly of note, I will move on to in the next slide. So just to recap on some of the physiology behind this, pregnancy produces a prothrombotic state. There's an increase in the natural coagulation factors and a simultaneous decrease in the natural anticoagulant factors, in addition to the venous endothelium and blood flow being altered from hormonal changes and the pressure that's produced from the gravid uterus, respectively. So whilst those latter two can be perceived or seen quite easily in healthcare professionals assessing patients in later pregnancy, perhaps those natural factor changes that are still occurring in early pregnancy may not be borne in mind as much. The incidence of VT is 1 to 2 per 1,000 pregnancies. And in late pregnancy, the risk is known to be 8-fold greater than it is in same age women outside of pregnancy. The first trimester is known to have a relatively lower risk of VTE, but as I showed previously, 1 in 4 of all deaths occurred in the first trimester. So this actually represents an excess of deaths. So the issues identified in the report assessing why this may be happening is the clear need for early and accurate VTE risk assessments at the first opportunity. So some patients who score highly enough, they will actually need thromboprophylaxis from a positive pregnancy test. And there's a gap similarly mentioned in the orthopedic studies where patients might be given up to 2 weeks of heparin if they're able to obtain it in primary care, but they need an ongoing supply early. And it was recognised that that's not always happening. The existing risk assessment tool, which I will show you shortly, it was identified that the multidisciplinary healthcare professionals using it, so this is midwives and doctors and also community healthcare professionals, reported that they found it difficult to use and understand and to apply to patients to understand their risk. And the timely access to the prophylaxis, so the lack of a clearly defined pathway of who is responsible for prescribing low molecular weight heparin in early pregnancy. So this report and the focus groups that we've had with women, as I mentioned, we would often hear of accounts where women knew that they were high risk and needed to obtain heparin prophylaxis, but they actually experienced enormous difficulty, lots of obstacles in obtaining it. And so one of the key highlights of the report was that updated research evidence is needed to restructure the existing national VT risk assessment tool. So with that in mind, this research was performed to support that. So this was a systematic review undertaken using PubMed and Google Scholar databases. And the existing tool incorporated data going up to 2015. So the focus here was to ensure that the already identified existing risk factors, do we still believe that those are significant risk factors, or should we be putting less or more focus on them? So we looked at that from 2015 up to March 2025. And search terms used were thrombophilia or VTE and pregnancy. And then the known individual risk factors were searched individually alongside pregnancy as well. In total, 892 papers were screened, and exclusions were where the study was not actually relating to the incidence of VTE. 35 were eligible for inclusion, and we agreed as a working group that the agreed risk factors that we would suggest be incorporated into the tool were where the adjusted odds ratio or relative risk were above 2. And this is to ensure that there weren't too many risk factors, and to ensure that healthcare professionals using it weren't overwhelmed with several risk factors to look at, and that we were really picking the most important. So this was the existing national risk assessment tool. And one of the key things discussed was that assessing early pregnancy, and you can see that it's almost a little of a distraction, the number of obstetric risk factors that are here. And of course, they apply at term pregnancy or the postpartum period. So these aren't applicable to early pregnancy. So our work was particularly focused on looking at these areas. And just so that you know how it works, women that score 3 points or more would then be eligible to receive thromboprophylaxis from 28 weeks of gestation. And women that scored 4 points or more are those that would be identified as needing it from a positive pregnancy test. And both groups would go on to need thromboprophylaxis for 6 weeks postpartum as well. And as you can see, this is the concern of this group that we have, is who is going to give them their thromboprophylaxis from a positive pregnancy test as needed. So I'm just going to take you through the updated evidence that was found. So SLE, this was already known to be a significant risk factor, and this is the established data that was already incorporated into the existing tool. So the new data found was that the relative risk was perhaps even higher than previously thought at 9.1, and studies were separating other autoimmune diseases there. So they're comparing with and without having antiphospholipid syndrome. But you can see in patients that did have primary APS, it's a very high relative risk there. And they also showed that having any autoimmune rheumatological disease had significant risk. So all of these clearly above 2, and we felt required inclusion into a new tool. BMI above 30, and again, of significance given that as a population basis, we have increasing BMI. And again, this was just found to confirm that the relative risk remains as previously known, and that this should be recommended for inclusion in the new tool. Age above 35, again, as a population, pregnancies occurring later in life compared to several years ago. Most studies here were comparing above and below 40, and as you can see, that demarcation is significant, the higher risk above the age of 40. Physical disability was a newer identified risk factor. So they found that there was a relative risk of 3, and they specified that this was in those requiring a mobility aid, so wheelchair or walking stick. If they didn't, then it was no longer found to be significant. Sickle cell disease, again, already known to be a significant risk, and as you can see here, very high. So 10.6 for any VTE and 11.1 for PE. And inflammatory bowel disease confirms previous understanding that there was no increased risk found where the disease is quiescent, but in patients who had a recent flare, then the risk remained significant, 2.64. This was new information for us. So gestational diabetes, we found that there's a relative risk for antepartum VTE of 2.48, although another meta-analysis found this to be below our significance threshold at 1.17. And it was noted, it's quite helpful information, that non-gestational diabetes was not found to be a significant risk factor. Possible newly identified risk factor of importance given the increased research into women's health and conditions such as endometriosis that have had less awareness and knowledge traditionally, and hopefully is now starting to. So one study found that women who had endometriosis, there was a relative risk of 2.7, which we would consider significant. And then those that had had endometriosis plus 3 or more pregnancy losses, actually you can see a much higher relative risk of 6.13. This was a prospective cohort study of 103,000 pregnancies between 2011 and 2014. But as this was the only study of this to date, we unfortunately couldn't recommend this to go forward for inclusion into a new risk assessment tool, but to just highlight that this is a potential area for further research if we were able to demonstrate that this is consistently found to be an increased risk factor. So assisted reproductive technologies, again, very important. The technology has come on mountains over the years, and we're seeing much more increased use. So a number of studies here. And something that was helpful information here in particular is confirming, as we know, that there's the significantly increased risk in the first trimester due to the exogenous hormones that are used to support the transfer, the new pregnancy, and finding that the mean incidence was at 62 days. When we're thinking about the duration of low molecular weight heparin that we might need to give to cover that risk in the first trimester. And again, confirmation that VT is occurring antepartum in these patients. And I think a particularly helpful piece of information here is a study that's compared transferring fresh and frozen embryos, where they found that where it was a frozen embryo transfer, the risk was greatly reduced compared to using a fresh embryo. So it might be that in patients that have a significant risk but want to be supported, consideration of a frozen embryo transfer might be something that could be incorporated into consideration. And then just further studies confirming again that increased risk significant above 2 and above 2. And one study showing in women that had PCOS that their relative risk was greatly increased further at 4.8 to their relative risk there. So in summary of the findings, we found that the risk factors that were previously identified and included in the National Risk Assessment Tool were confirmed to remain significant risk factors, which is addressing the Embrace request to have a updated evidence base supporting which risk factors are included in the tool. And we also found some potential significant risk factors for consideration in future versions of the tool if further studies were present to allow inclusion, such as the endometriosis with recurrent pregnancy loss, and information regarding assisted reproductive technologies and potential strategies to reduce the risk, such as the frozen versus the fresh embryo transfer. So those are my references, and thank you for listening.
Thank you, Francesca. So there is a question here, and I'm going to read it out, and you can choose to answer it or I can choose to answer it. So it says, do you think our protocol of having first trimester managed by gynecology rather than obstetrics lets our first trimester patients down? Often significant presentations like hyperemesis present to essentially a surgical area where the risk assessment tool does not consider pregnancy. I suspect midwives and obstetricians would be more astute to this.
Yes, that's something discussed a lot in our working group, particularly about hyperemesis and the risk around that. and the setup in different hospitals about maternal medicine support, because women that are later in pregnancy will automatically get a obstetrician or a maternal medicine review, but women in their first trimester wouldn't necessarily. So indeed, our working group absolutely has discussed the importance of, at the very least, perhaps a discussion, it being included in pathways that if somebody is pregnant, that it is discussed. Because whilst not covered in this presentation, other significant topics are people who've had recent pregnancy loss and their ongoing risks. So if they present to hospital having recently been pregnant, they've still got a significant risk of VTE for 6 weeks after. And the same for women who have had termination of pregnancy, it's the same. So yes, I think things could be missed in terms of current setup and support for medical and surgical teams to have the opportunity to discuss recently pregnant women or women early in pregnancy with a gynecologist would be very important.
Yeah. So currently, the Royal College of Obstetricians is rewriting its guidance, and it's rewriting its guidance for maternity care. And then the Department of Health, because they're so worried about this issue, have taken on producing a first trimester risk assessment tool, which could be used by individuals. So it's patient, pregnant woman friendly, and also can be embedded on websites. So, for example, when women book, 75% of women will book now directly to the hospital. They could do something there, and it's hopefully be coming out and be announced by the minister in a couple of months. So that's going to be fascinating. Right, thank you so much, Francesca, for giving us that update on risk. And we have to see what the Royal College of Obstetricians do and whether they agree.